Everybody. I think that Walid, he mentioned a few points that's very important related to the rehabilitation and the cross-linking for the keratoconus. So once we decide to cross-link a patient with a keratoconus, we need to say that, or we need to think that this patient need rehabilitation. And once we cross-linked, the options for rehabilitation will be limited, especially when we are thinking about the laser post, as Walid said, where still the debate is in, and deeply to think about when we are treating across, because we will not treat the high order abrasions, and when we are thinking about refractive lens with high order abrasions, then the patient will not, the vision will not improve. So, from this point of view, we have what we called the KRIS. KRIS with the, let us say, the allogenic ring. And with the allogenic ring, the keratoconus remain a significant complication that need to be treated, as I said. Traditional management include the synthetic ring, cross-linking, and transplantation. KRIS introduced a new era in biological alternation using donor corneal tissue. The corneal allogenic intrastromal ring segment is a lamellar corneal implant technique. It's utilized donor corneal tissue shaped into a ring segment. The goal is to improve corneal shape and achieve a biomechanical stability. So it will improve the maps and improve the visual outcome, and it gives some biomechanical stability. Now, that's, if we will say, that how the KRIS will stay inside the cornea. And the allogenic stay very safe because it's allogenic, so we will not have the complication that we had it with the PMMA rings. So that's part of the issues. And with the allogenic, we can reach up to 5. Some protocols, they reach 4.5. I didn't reach below 5. And we can go superficial up to 200. But still there is a complication with the 200, so I didn't reach up more than 250. In a classical ring, 100% we will have multiple complication, erosion, and when we are reaching superficial, and when we will reach less than 6 or 5.5, we will have a lot of halos. Patient cannot drive, patient cannot walk at night. The incision, all we are agreed that it's on a steep meridian, creation of intrastromal canal, manually or femtosecond. I prefer femtosecond. Preparation of a donor corneal tissue into a ring segment. Thanks God that we have now companies, I don't have any financial enclosure, that they are preparing according to what we need. And I'll show you the protocol that I'm following. And Kera Natural, they are doing it according to the need of the surgeon and according to the requirement of the length, thickness, and as I said, the important things is the thickness and the length of the ring. Insertion of the segment into the stromal pocket. That also, we are, me personally, I'm following the dry technique. So I'm drying the segment and then insert it. Now, the protocol that have a lot of controversy, and when we start, all of us, we follow the protocol of Turkish that they, by default, they put the ring as inner circle in 4.5, and they don't consider the inner circle as a part of the nomogram. They consider that following the K reading, the highest, the more thickness, the more superficial, the more inner. With this protocol, it will follow the refractive outcome. So, because what we faced in the previous protocol, that we are facing a hyperopic shift. And when we have hyperopic shift, then we will stuck with the treatment pause. And it will be very difficult to treat those patients when you have mixed hyperopia. So this protocol, you can say that it consists on the refractive. By this, we reduce the K reading and we prevent hyperopic shift or hyperopic mixed astigmatism. So when we are look at the first in the sphere from 0 to 1, 1 to 3, 3 to 6, it shows the inner, because the inner will affect the outcome of the sphere. So 6 to 8 means that the tunnel, the 6 is inner. In 0 to 1, minus 1 to 3, the inner will be not less than 5.5, and from 3 to 6, it should be 5. Otherwise, we will have hyperopic shift. The tunnel here, we are using 2. If we use 4 millimeter tunnel, I was discussing a lot with the Turkish lady that she was doing. So 4 millimeter with the ring, which is 1.9, so it's floating inside that, and it has no effect. The effect is from the stretch that the ring can create it inside the tunnel. So the max, definitely, it's 2 for us. 100% for 4 millimeter tunnel, it's easy to implant, but has no any effect. For the cylinder is the thickness of the length and thickness, the length and depth and thickness of the ring. So from 1 cylinder to 1 ring, 6 millimeter, 350 the depth, and 500 micrometer the thickness. The last 6, we need to have 2 ring, 8 millimeter length, 250, 600 to 700 micron. Here in this way, we will definitely, when we are talking about the ring, it's not a precise result, but our aim is to reduce as much as possible the high order abrasions and the low order abrasions, especially the cylinder. Now, if we will go to the improved definitely visual acuity, biocompatibility, it's better than the PMMA, reversible and adjustable. We can remove it, we can cut it, we can shortening it, we can have half of the ring and avoid the synthetic material related complication, can delay or avoid keratoplasty. We are using it in a mild to moderate stage. I'm using it for also for the end stage. Post LASIK ectasia, yes. Pillow side marginal, yes. Irregular astigmatism also, yes. The study showed significant flattening of the Kmax and improvement in the best corrected visual acuity, stable result up to 36 months. No rejection or extrusion reported in most of the cases. KRIS represent a promising biological and minimally invasive solution for the corneal ectasia. It combined the biomechanical support of ring segment with the safety of the allogenic tissue. Further long-term study will help to establish the nomogram and case presentation. You can see that the case on the right, that was indicated for the KRIS case. For the left was indicated for the trans-PRK and cross-linking. I believe in a same session. So if we'll go to the right, we can see that the pre-op KRIS was the unaided 0.3 minus 2.75 minus 7. Higher order abrasion was 3 and comma was 2.8. So the incision was on 1.4, inner 6.5, outer 8.5, depth 300, thickness. Can you please just return me to the slide, please, Dr. Murad?
Yeah, please. Please give him 1 minute from the discussion, Dr. Safwan.
Okay. So that was a pre, and I'm using the tangential. It's not moving. And that's the elevation map, high order abrasion, and that's how we are drying the segment around 30 to 40 minutes. And this, the surgery, femtosecond, and then the tunnel, then with the tools that 100% we need the special tools for it, and implant the segment. You can see the segment start to be dry. I'm opening it from both in a way that I can stretch from the other side if I have any difficulties to implant. So you can see it's just like a PMMA ring, and you can easily slipping it inside. And when you have any difficulties, then you can go from the other side and take it. Thank you very much for it.